By happy chance, I earlier in the week gave a talk on bariatric surgery in adolescents. So this talk is focused on what is the future for adolescent bariatric surgery and where that field currently is and where it needs to go in the future as a model for treatment for adolescent bariatric surgery. So new guidelines just came out. They are actually in press. They're not actually published, but they're up online. You can find them. Janie Pratt at Stanford is the first author. They're in SWORD. And these are slightly different than the previous bariatric surgery guidelines that have been used for the past decade, and I'll try to highlight some of those differences. So the indication for, and now they want it to be called metabolic and bariatric surgeries, or MBS, is a BMI greater than 35 or 120% of the 95th percentile, with one or more comorbidities, and they can include any of these listed below: sleep apnea, NASH, type 2 diabetes, Blount disease, GERD, or just simply having a BMI above 40 with no comorbidities necessary for treatment. It's different than it was before. You used to have to almost always have a comorbidity. And that a multidisciplinary team should be used for the consideration of this both pre-op as well as post-op. And so some of the contraindications for metabolic and bariatric surgery have actually changed. That it must be a medically correctable cause of obesity. And what they mean by this is that monogenic forms of obesity don't necessarily fall under this auspice of these new guidelines. If you have something like Prader-Willi syndrome, hypothalamic obesity, these have to be considered as separate cases of obesity. Ongoing substance abuse problems, probably going to need to reject those individuals within the preceding year. Psychiatric or psychosocial disorders, as well as cognitive conditions like Down syndrome that may prevent adherence to the post-bariatric regimen that is necessary to be healthy in the post-bariatric setting. Being able to stick to the post-operative dietary and medication regimens, and anyone who is planning to be pregnant within the next year to year and a half should not undergo the procedure. The other difference that I will note that is different from the other previous guidelines is there's no guideline in terms of pubertal maturation. Previous guidelines suggested that individuals had to be Tanner stage 5, so full pubertal maturation, or from a bone scan show that fusion of growth plates. That recommendation has been removed from the new guidelines based on no evidence to show that bariatric surgery inhibited growth or inhibited pubertal maturation, which is really important because now you can indicate bariatric surgery for pretty much anyone above the age of 10, which will be controversial. So the best evidence that we have for bariatric surgery right now in the US is the Teen Lab study. Very similar evidence in Sweden from the AMOS study. Torsten Olbers, who's supposed to talk, it was the PI of that study. Teen Labs, though, is a prospective multi-center observational study of adolescents enrolled less than 19 years old who underwent metabolic and bariatric surgery in the early, from 2007 to 2012. 242 individuals were enrolled in this original cohort. 65% of them ended up getting Roux-en-Y gastric bypass. 30% of them ended up having this vertical sleeve gastrectomy, and about 5% had the lap band procedure. Mean BMI in this cohort is 53 or 30 or about 150 kilos. And this is the weight change from baseline using the two main procedures, the sleeve and the gastric bypass at 3 years. This was published in New England Journal a number of years ago, but you see about a 30% reduction in body weight. And this, I can tell you, will be sustained out to about 5 years in the same cohort. And so the next question becomes, where do we go from here? All right, so bariatric surgery produces substantial weight loss. There's no difference actually between surgical types. There's a very large study from PCORI data in adolescents, much larger than this sample size, published in SWORD last month. Tom Inge is the first author, showing no differences between the sleeve and the bypass in terms of weight loss in adolescents. But where do we go? What else do we need to know from bariatric surgery? And we have some opportunities here. We really need to understand the long-term, both good and bad complications of bariatric surgery. And why is there no lack of difference between surgical types? The SOS study in Sweden in adults showed very clearly that sleeve gastrectomy produces a little bit less weight loss than the Roux-en-Y gastric bypass, and that the Roux-en-Y gastric bypass also has greater improvements in type 2 diabetes, as well as some important comorbidities like hypertension and dyslipidemia. But we're not observing those in kids, and is it because our follow-up period is not long enough, or are these mechanisms of action different in adolescents than it is in adults? Or is it potentially something like duration of disease? We need to understand that. We need to understand the difference in metabolic effects long-term, and we need to really understand the long-term consequences. In order for bariatric surgery to, its uptake to go up. So right now in the US, less than 1% of the kids who qualify for bariatric surgery, medically qualify for bariatric surgery, get the procedure. And so, and partly this is because of the risks of the procedure, but also I don't think we understand the long-term consequences. As soon as we understand the long-term consequences, we can really tell a patient, hey, this is what you're going to get into. These are the potential side effects that you're going to have not only next week after surgery, but 10 years down the line. And we also need to understand some of the heterogeneity that Dr. Kelly was talking about. So this is a publication that came out last year in the International Journal of Obesity, where we looked at a surgical cohort and looked at the ability of individuals to maintain weight loss long term. So we have 3 time points here. If we look at just the blue bar, this is a baseline. Then they had Roux-en-Y gastric bypass, it's 50 individuals. And weight loss at 1 year is around a 40% BMI reduction in this cohort. Pretty substantial weight loss. And then we have a follow-up of bariatric surgery at least 5 years from the 1 year time point. Mean follow-up actually in this cohort is 8 years. The range is 5 to 12 years. And what we observed overall is the ability to maintain the weight reduction long-term is about a 30% BMI reduction. But we observed 2 distinct groups of individuals. One group of individuals, about 50% of the cohort, was able to maintain that weight loss long-term. And one group of individuals gained back a proportion of their weight. And we selected maintainers and gainers based upon being able to stay within that 1 year weight loss within 20%. So they had to stay within 20% to be a maintainer. If they gained more than 20%, then they were put into the gainers group. We wanted to look at, is there anything different between those gainers and maintainers in terms of behavioral patterns, such as dietary patterns, physical activity patterns, as well as how they interacted in their social environment with their families. We found no differences. They all have really poor diets. They all have really poor physical activity patterns. They're all very sedentary, and they all hate their parents. And you know, it was kind of surprising to us that we didn't find any differences, but it suggests to us that there's probably other mechanisms at play, but we also need to understand some of that our measurement tools. We use questionnaires probably are not sensitive enough to detect some of the differences between those 2 groups. The other nice thing about this, though, is that we have a control group. So these are individuals that qualify for bariatric surgery but just don't get it. They get specialty pediatric weight management that we talked about earlier in the first talk, and that's our control or comparator group, our non-surgical comparator group. We brought them back at the same follow-up time point, and they on average gained about 10% of their BMI over that same mean 8-year follow-up period. So even this gainer group that gained 20% of their BMI back after surgery is substantially better off than this control group that didn't get surgery. And you know, Dr. Kelly at the end of his talk showed our treatment void that was just published in Obesity. We need to find a gap in here. We need to figure out how we can get individuals that don't want to have bariatric surgery still have a weight loss lower than that, but we also need to understand the mechanisms. So I would argue that this gainer group is also unacceptable. Somebody who undergoes a bariatric surgery procedure should be able to maintain that weight loss long term. For them to gain back any proportion of their weight is unacceptable given the life-altering consequences of having that procedure and also the risks of it. So we need to also think about post-bariatric interventions, whether it's lifestyle, pharmacotherapy, or a combination of the two is going to be likely necessary for a lot of people who have this disease. But the challenge with implementing pharmacotherapy is a lot of the pharmacotherapy agents that have been developed, the pathophysiology of those are changed by surgery. So GLP-1 receptor agonists, for instance, will not probably work or be an effective treatment post-bariatric because GLP-1 physiology is altered after bariatric surgery. So something we can consider, something like phentermine. We published this paper in IJO in 2016. In the blue, we have phentermine plus standard of care lifestyle in our pediatric weight management clinic. And we see about a 4% mean reduction in adolescents with severe obesity compared to our standard of care who did not get phentermine. We also need to look at other mechanisms of how bariatric surgery is altering physiology. And so we published this paper a couple of years ago, and we looked at inflammatory cytokines, interleukin-6, oxidative stress, oxidized LDL, adiponectin, and all of these were improved in the right direction. The interesting one to me was leptin. And so when we originally started measuring leptin, we got the assays back from the lab and everything was off the charts, off the sensitivity range prior to bariatric surgery for these individuals. So we had to go back and rerun all the assays again. Just shows you how high their leptin levels are, and it makes sense because if you interact with somebody prior to bariatric surgery and they say, you know what, I eat a meal and I'm still hungry, I'm still starving, I'm insatiable, well, the leptin levels don't lie. These are off the charts, literally off the assay charts. And so we measured them after bariatric surgery, and you can see a substantial reduction in the leptin levels, and these are actually similar to what we would observe in a normal weight child. So bariatric surgery does a lot to pathophysiology, and we need to really get a better understanding and characterization of those effects. So other future avenues for research in bariatric surgery, we need to understand the weight loss dependent and independent effects of bariatric surgery. And what I mean by this is some risk factors and comorbidities are highly dependent on body weight reduction. For instance, in the Teen Lab study, they had 32 individuals who had type 2 diabetes. 95% of them had resolution of that type 2 diabetes at 3 years, which is remarkable considering in adults it's only about 65 to 70%. Substantially better outcomes. And this is highly associated with weight loss. They have to get that 30% weight loss in order for that to be achieved. And it's substantially better than what we observe in adolescents in those who get medical management for the disease. But we know that other things are completely independent of weight loss. For instance, we published a paper a couple years ago on musculoskeletal improvements after bariatric surgery. When we included weight loss into our modeling, there was no association between weight loss and improvements in musculoskeletal pain that we observed. So we know that there are some mechanisms of bariatric surgery that are dependent on the weight loss produced, and some are going to be independent mechanisms, and we need to understand those better. We need to understand some of the barriers to individuals who medically qualify for bariatric surgery actually having the procedure, and in order to get greater uptake of this procedure. There are a lot of kids that could really use this procedure that are just not getting it. I would argue that any adolescent with type 2 diabetes, this should be the first order of treatment because today's study has clearly shown that medical management of type 2 diabetes in adolescents is just not going to cut it. And we need to figure out how we can get these individuals reimbursed and how we can get them treated so that we can mitigate this disease. And then we really need to look into pre and post-surgical interventions in order to reduce the complications, improve outcomes, make sure that nobody gains weight after the intervention so that we can have successful outcome. And that's all I got. Okay.